You're sitting in clinic, and a patient walks in, lifts their shirt, and, well, there it is.
Right. A distinct, entirely unmistakable bulge along an old midline scar.
Yeah, and the skin over it is, perhaps slightly thinned out. Maybe it has that faint redness from, like, the friction of their waistband.
It's a clinical presentation you will encounter relentlessly throughout your career as a surgical registrar.
But here's the deeply uncomfortable truth that we have to confront right now from the very first minute of our deep dive today.
Yeah.
That hernia sitting in front of you. It's a complication we created.
I actually prefer to phrase it with absolute clinical detachment. Every single incisional hernia begins as a failed laparotomy.
Wow. Yeah, failed laparotomy.
Exactly. Before we even consider, the intricacies of surgical repair, I want you to internalize one stark reality. The fascial defect you're palpating in clinic today is a definitive, undeniable verdict on a closure that occurred months or maybe years ago.
Right. It's a verdict.
Sometimes it's the verdict on an operation performed by a senior colleague. And sometimes, well, you pull up the operative note and you realize it's the verdict on your own hands.
That's a profoundly heavy realization to carry into the exam room with you.
It absolutely is.
You look at that distended contour and you are quite literally examining surgical history. But we need to quantify this. How often are our midline closures actually failing in the long term?
The epidemiological data is incredibly humbling, to be honest, particularly when researchers use rigorous long-term radiographic follow-up rather than just relying on, a patient self-reporting that they feel a bump.
Right, because patients miss things.
All the time. Depending on the series, somewhere between 10 and 20% of all standard midline laparotomies will eventually develop an incisional hernia.
10 to 20%.
Yes. And if you're dealing with a high-risk cohort, so the morbidly obese, the contaminated damage control laparotomies, or patients who got a postoperative surgical site infection.
Oh, I imagine the numbers jump up.
That failure rate skyrockets well past 30%.
30% failure rate in high-risk groups is, that's not just a minor footnote in a textbook. That represents a massive systemic population-level issue.
It does. It's an epidemic.
Which leads to a rather chilling takeaway, How you choose to close an abdomen at 2 in the morning today directly dictates the surgical disease burden that you and the wider healthcare system will be forced to operate on 5 years from now.
It's one of the few distinct areas in our specialty where our technical execution today directly engineers the pathology of tomorrow. We are literally generating our own future workload.
So before we can even begin to evaluate the complex algorithms of reconstruction, we have to earn that right. We have to systematically unpack the failure.
Yeah.
But why does that happen? Why does a closed abdominal wall fall apart?
To crack that open, we need to completely abandon the simple idea of, tissue tearing. We have to think strictly in terms of biomechanics first and then molecular biology.
Okay, biomechanics first. Walk me through it.
Mechanically, you have to stop visualizing the abdominal wall as these static layers of fascia and muscle. You need to conceptualize the core of the human body as a dynamic, load-bearing pressure vessel.
Right, pressure vessel.
It obeys the laws of physics, specifically Laplace's law.
Ah, right. Where wall tension is proportional to the pressure inside the cylinder multiplied by the radius.
Precisely. So think about what the patient does. Every time they cough, every time they bear down in a Valsalva maneuver to, have a bowel movement, or every single time they recruit their rectus complex just to sit up in bed.
They're spiking the pressure.
Right. They are generating acute spikes in intra-abdominal pressure. And this translates into significant hoop stress acting upon that cylinder. All of that outward radial stress directly loads the linea alba and the monofilament sutures you just placed.
Let's translate that physics into the timeline of actual tissue healing. So you tie your final knot, you cut the suture, the cavity is sealed.
Yes.
But the tissue itself has to undergo the entire inflammatory and proliferative cascade to eventually, take over that mechanical load from your suture material. What's the actual kinetic timeline of that strength recovery?
Well, it proceeds agonizingly slowly. The aponeurotic fascia, the linea alba, is it's relatively avascular compared to the highly perfused muscle bellies right next to it.
So it doesn't get the same blood supply.
Exactly. It relies on a very gradual process of fibroplasia. During the initial lag phase of wound healing, so the first 4 to 6 days, the wound has essentially zero intrinsic tensile strength.
Wait, 0.
Functionally 0. It relies entirely on your suture.
Yeah.
And then by 6 weeks post-operation, which is at the peak of the proliferative phase, the fascia has only regained about 50% of its original preoperative tensile strength.
Okay, and I imagine it plateaus eventually, but I mean, does it ever reach its baseline strength again?
It never fully recovers, never. Even after a full year of extensive collagen remodeling and cross-linking, the scar tissue will never exceed 70 to 80% of the strength of native uncut fascia.
Wow.
So you have this incredibly vulnerable window, particularly in the first 30 days, where the physical mechanical load of just simply living, breathing, and moving frequently outpaces the biological strength of the maturing scar.
If the load outpaces the intrinsic strength in that first 30-day window, that implies the actual structural failure is happening, like, almost immediately.
Yes.
So an early hernia isn't something that develops 2 years later. It's just the mechanical disruption that occurred early on but hasn't fully announced itself to the outside world yet.
You've hit the exact core issue. The classic surgical teaching, which is heavily supported by sequential ultrasound studies, is that the vast majority of incisional hernias happen subclinically within that very first month.
Subclinically, so you can't even see them.
Right. The fascial edges have microseparated. The continuous suture line has either, pulled through the ischemic tissue or the knot has slipped. The mechanical integrity is lost. But you don't visually perceive it yet on the outside.
It's just hiding into the fat layer.
Exactly. It often takes 1 to 2 years for that subclinical microscopic defect to visibly enlarge as the omentum and intra-abdominal contents slowly, persistently wedge their way into the gap. And that's driven by that constant intra-abdominal pressure we talked about.
Which provides us with a highly actionable clinical pearl right out of the gate, doesn't it? A patient who presents to your clinic at 3 months post-op with a flat, pristine abdomen and 0 complaints, they're absolutely not a cleared patient.
Not at all. They could easily harbor a 2-centimeter fascial dehiscence deep down, just waiting for time and intra-abdominal pressure to do their work.
You simply cannot give them a definitive clean bill of health at 3 months. You have to operate under the assumption that if mechanical failure was going to occur, the primary event has probably already happened, but the clinical presentation is delayed.
Exactly. However, mechanical failure, the physics of the pressure vessel we just discussed, that is only half of the story. The intrinsic biological substrate of the patient is just as critical to understanding the failure.
Okay, I'm going to push back on that slightly. Let's look at a perfectly controlled scenario.
Okay, go ahead.
You have 2 patients, similar age, similar BMI. They undergo the exact same midline vertical incision for, say, an elective phygmoid resection. You apply the exact same meticulous technique and close them both.
Right.
You use the same slowly absorbable suture, the same needle, the exact same bite depth. But 5 years down the line, patient A has a beautiful pristine scar, and patient B has a prominent W2 incisional hernia. If the mechanics were absolutely identical, what drove the failure?
The biology of failure, and this is the part that frequently surprises residents who are, solely focused on tying perfect surgical knots.
Right, we get obsessed with technique.
Decades of biochemical research have revealed that patients who form recurrent hernias often exhibit fundamentally altered collagen metabolism. In a normal, robust abdominal wall, the extracellular matrix is built primarily of mature type I collagen.
Type I.
Yes, you can visualize type I collagen as densely packed, highly cross-linked steel cables. It provides formidable tensile strength.
And the alternative is type 3 collagen, correct? The provisional matrix.
Exactly. Type 3 collagen is the immature provisional matrix that gets laid down really rapidly during the early phases of wound healing. Visually, think of it as weak, disorganized twine compared to the steel cables.
Okay, twine versus steel.
In patients who are predisposed to herniation, we observe a distinct biochemical shift. Their ratio of type I to type 3 collagen is pathologically altered in the skin and fascia, yielding relatively more of this immature, weak type 3 collagen at the expense of the mature type I.
So they are actively constructing a biologically inferior scar from the molecular level up. The building blocks themselves are flawed.
The building blocks are flawed, yes, but the pathology goes even deeper. Furthermore, these same patients frequently demonstrate unregulated activity of matrix metalloproteinases, or MMPs.
MMPs, right?
Yeah, MMPs are the specialized zinc-dependent enzymes responsible for degrading and remodeling the extracellular matrix. Now, in a healthy healing wound, MMP activity is really tightly controlled by tissue inhibitors.
It's balanced.
Right. But in hernia-prone patients, the MMPs are hyperactive. They are literally cleaving and degrading the collagen matrix significantly faster than the local fibroblasts can synthesize it.
So if the degradation outpaces the synthesis, we're looking at a scenario where a hernia is not simply a mechanical tear caused by a cough. Hernia is, at its core, a systemic collagen disease.
Yes, and this reframes the entire patient sitting on your exam table. When you evaluate a patient presenting with an incisional hernia, and you note on their chart that they also have an umbilical hernia, a history of bilateral inguinal hernia repairs, and maybe diverticular
We're
disease.
not just looking at a chronological history of inadequate surgeons.
Exactly. You are battling a fundamentally compromised biological substrate.
This totally alters the internal dialogue when you're evaluating a recurrence. It implies that a recurrence isn't entirely a reflection of your surgical aptitude. Sometimes the tissue itself is just destined to fail.
Right.
But as a thinking surgeon, you must hold both of those concepts in your mind simultaneously, right? You have to rigorously question, did I execute the closure poorly? Right alongside, is this tissue inherently working against me?
You must hold both to account because you can't rewrite their genetic code. You cannot currently administer a drug that permanently normalizes their collagen ratio, but you absolutely can and must modify your surgical technique to provide their inherently weak biology with the best possible mechanical advantage.
Okay, so if we acknowledge that the molecular biology is stacked against a certain subset of patients and the physical mechanics are a constant threat to everyone, how do we actively prevent this complication? Let's systematically structure the threat.
Good approach.
Let's break down the risk factors, exactly how a registrar needs to articulate them during morning ward rounds, categorized by pathophysiology.
The most robust framework categorizes them into patient, operative, and postoperative variables. Commencing with the patient. Obesity is the undeniable primary driver, and we must understand why.
It's not just the technical challenge, right?
No, it isn't just about the technical difficulty of retracting adipose tissue. Obesity chronically elevates resting intra-abdominal pressure. A normal abdomen might have a resting pressure of, say, 5 millimeters of mercury. A morbidly obese abdomen might rest at 15 or 20.
So a baseline is already dangerously high.
Yes. It converts a standard pressure cylinder into a chronically overloaded boiler, constantly exerting outward radial force on the healing fascia.
And then we look at systemic perfusion and oxygenation. Smoking is frequently cited, but let's look at the cellular level. Why does smoking specifically cause fascial dehiscence?
It is a dual-pronged assault. First, nicotine induces profound peripheral vasoconstriction, clamping down the delicate microvasculature that supplies the aponeurosis.
So less blood flow right to the scar.
Exactly. Second, carbon monoxide displaces oxygen on the hemoglobin molecule, shifting the dissociation curve. So the local fibroblasts are quite literally starved of the oxygen required for proline hydroxylation.
And without hydroxylated proline?
Without it, the collagen triple helix cannot properly cross-link. The scar remains incredibly weak. Add to this diabetes, where advanced glycation end products impair macrophage function and stall the inflammatory phase. You also have to factor in severe malnutrition, chronic corticosteroid administration, which completely halts fibroplasia, innate connective tissue disorders like Marfan or Ehlers-Danlos, male sex, and advanced age.
That covers the innate patient variables.
Yeah.
Let's transition to the operative factors, the variables we directly control in the theater.
The anatomical orientation of the incision is a massive primary variable. The data clearly demonstrates that midline vertical incisions herniate at a significantly higher frequency than transverse incisions.
Let's explore the vector mechanics behind that. Why does a vertical incision fail so much more often than a transverse one?
Consider the dynamic anatomy of the abdominal wall. The lateral muscular layers, so the external oblique, internal oblique, and transversus abdominis. They originate laterally and wrap circumferentially around the torso, inserting into the central aponeurosis, the linea alba.
Right.
When those muscles contract during respiration or movement, the primary vector of force is lateral. A midline vertical incision divides the tissue directly parallel to the linea alba. Consequently, those lateral muscles are constantly pulling the two edges of your fresh wound apart.
They're actively tearing it open.
Yes. A transverse incision, conversely, divides the tissue parallel to the primary tension lines. The contraction of the lateral muscles actually brings the edges of a transverse incision closer together.
That translates perfectly to the operating room. A transverse closure physically works with the innate muscular dynamics, while a vertical closure literally fights against them. What other operative factors influence failure?
The clinical context of the operation. Emergency damage control laparotomies exhibit very high failure rates due to systemic shock, tissue edema, and simply the inability to perform a meticulous elective closure. Furthermore, gross contamination such as fecal spillage from a perforated colon severely impairs the normal fascial healing cascade.
Because the body's too busy fighting infection.
Right. The local immune response shifts entirely toward clearing the bioburden rather than synthesizing collagen.
Which provides a seamless transition to the postoperative variables. What is the paramount red flag we are monitoring for on the surgical ward in the days following the index operation?
Surgical site infection. An SSI is a devastating event for fascial integrity. It roughly doubles the risk of subsequent incisional herniation.
Doubles it? Wow.
Yes. The proliferating bacteria and the ensuing profound, unregulated inflammatory response physically destroy the fragile early collagen matrix. The neutrophils release proteases that literally liquefy the developing scar.
So if your patient develops a deep fascial space infection, you must virtually anticipate a future hernia.
It's almost guaranteed. Couple that with post-operative pulmonary complications like a severe pneumonia causing violent coughing or a prolonged paralytic ileus resulting in massive bowel distension. Anything that acutely spikes the intra-abdominal pressure during that initial 30-day window of biological vulnerability.
When you lay it out physiologically like that, it becomes incredibly apparent how many of these variables are entirely modifiable in the pre-anesthesia clinic, long before a scalpel is ever utilized.
Very true.
We can aggressively optimize their glycemic control, we can strictly mandate smoking cessation, and we can initiate medical weight loss. But let's place ourselves in the operating theater. Let's analyze prevention at the index operation, because the absolute optimal hernia repair is the one you never have to perform.
This is where surgical discipline and an intimate understanding of tissue mechanics are paramount. For decades, the prevailing surgical dogma, passed down from attending to resident, was to take extensive, wide bites of tissue when closing the midline fascia.
Right, the intuitive logic was simple. Incorporating more tissue volume into the suture loop will mathematically result in a stronger, more secure hold.
Exactly. The classic, if a little is good, a lot is better mentality. You take a full centimeter bite, grabbing a substantial portion of the rectus abdominis muscle along with the anterior and posterior rectus sheaths, and you just reef it down tightly.
And we now understand that this approach was biomechanically disastrous.
Disastrous. When you encompass a large volume of fascia and highly vascularized muscle within a tightly secured suture loop, you immediately overcome the local capillary perfusion pressure.
You choke the blood supply.
You do. The tissue trapped within that loop becomes acutely ischemic. Over the subsequent days, that ischemic muscle and fascia undergo coagulative necrosis. They die.
And as that trapped tissue necroses, its physical volume actually diminishes.
Precisely. As the tissue volume shrinks within the fixed loop of the suture essentially becomes loose. The mechanical purchase is entirely lost. The outward radial force of the abdomen then easily pulls the suture right through the necrotic tissue, creating a fascial dehiscence.
This biomechanical understanding paved the way for arguably one of the most important trials in abdominal surgery, the STITCH trial.
Yes. The STITCH trial fundamentally dismantled the large bite dogma. It provided level-eye evidence that the small bites technique is vastly superior for preventing incisional hernias.
Break down the technique for us.
The technique dictates taking only 5 to 8 millimeters of purely fascial aponeurotic tissue from the wound edge and placing those bites very close together, approximately 5 millimeters apart.
5 millimeters, that's tiny.
It is, and crucially, utilizing a slowly absorbable monofilament suture such as PDS.
Let's visualize the physics of this approach. By taking only 5 millimeters, you are suturing exclusively the strong, collagen-dense aponeurotic tissue, the true structural fabric of the abdominal wall. You are deliberately excluding the highly vascularized, easily necrotic red muscle from the suture loop entirely.
Yes. You are distributing the overall tension of the closure across many small, precise points of structurally sound aponeurosis, rather than concentrating the force on a few large points of weak ischemic muscle.
It's akin to the engineering principles used in, like, ripstop nylon or the distribution of load-bearing cables in a suspension bridge.
Exactly. And this small bites technique must be paired with another fundamental biomechanical concept, the Jenkins rule, or the golden ratio of wound closure.
The 4.1 suture-to-wound length ratio.
Correct. The total length of the suture material utilized must be at least 4 times the total length of the fascial incision. If you are closing a 10-centimeter laparotomy wound, you must document using at least 40 centimeters of suture to achieve that closure.
Let's explore the physics there. Why is a 2.1 ratio insufficient? Why do we need so much redundant suture material within the wound?
Because the abdominal wall is not a rigid piece of wood, it is highly compliant. When the patient takes a deep breath, coughs, or experiences postoperative bowel distension, the entire abdominal wall stretches and the wound lengthens.
It moves.
Right. If your suture-to-wound ratio is too low, say 2.1, the suture acts as a rigid, unyielding wire. As the abdomen expands, the rigid suture cannot accommodate the stretch, and the immense focal pressure causes it to slice directly through the fascia.
But a 4.1 ratio.
A 4.1 ratio, achieved through many continuous small bites, functions mechanically like a coiled spring. It grants the closure elasticity, allowing the suture line to expand and contract in perfect harmony with the dynamic physiological movements of the abdominal wall without shearing through the tissue.
That is a beautiful application of structural engineering to human tissue. But I want to introduce a slightly different scenario. The small bites technique and the 4.1 ratio are exceptional for elective closures. But what if we are dealing with a patient where we know, unequivocally, that the underlying biology is completely hostile from the moment we make the incision?
This is where we look to the PRIMA trial. The investigators of the PRIMA trial evaluated the concept of prophylactic mesh augmentation.
Prophylactic mesh.
Yes, they posed a critical question. If we identify a patient who possesses an extraordinarily high risk of fascial failure, for example, a morbidly obese patient, or a patient undergoing open repair of an abdominal aortic aneurysm, a pathology that inherently implies a systemic degradation of collagen and elastin, should we preemptively place a synthetic mesh at the time of the index operation to reinforce the primary closure?
And did the data support leaving a foreign body in a primary closure?
It did. In these highly selected high-risk cohorts, placing a prophylactic mesh, typically in the sublayer onlay position, significantly reduced the subsequent incidence of incisional hernias compared to suture closure alone.
So we're actively altering their biology with hardware.
To be clear, this is not a blanket recommendation. You would not subject a young, healthy trauma patient or a routine appendectomy to prophylactic mesh. But for the severe, high-risk phenotype, it represents a proactive, evidence-based strategy to overcome a hostile biological substrate.
The overarching lesson here is profound. Picture the environment. The mass closure at the conclusion of an exhausting 6-hour complex oncology case. The primary tumor is out, the anastomosis is complete, the surgical team is fatigued, and everyone in the operating theater is anticipating going home.
Yes, the danger zone.
When you are handed that heavy needle driver, that is the precise moment your surgical discipline is tested. That is when you are determining whether this patient will be sitting in your hernia clinic in 2 years.
I remind my registrars constantly. The primary operation is not concluded until the skin is approximated. The fascial closure is a critical operation unto itself, demanding the exact same level of focus and physiological understanding as the bowel resection that preceded it.
So despite our rigorous application of the STI-TCH principles, let us assume the closure eventually fails. The patient returns to your clinic presenting with a symptomatic bulge. How do we initiate communication regarding this complex anatomical defect with our surgical colleagues? Simply documenting the patient has a large ventral hernia is clinically useless. We need a precise nomenclature.
We require a standardized, internationally recognized language, and that framework is provided by the European Hernia Society, or EHS, classification system. It mandates mapping the defect based on 2 primary coordinates, location and width.
Let's orient the listener to this coordinate system. Walk us down the abdomen.
For midline incisional hernias, we classify the location from M1 down to M5. M1 represents the subxiphoid region immediately inferior to the sternum. M2 is epigastric. M3 encompasses the umbilicus. M4 is the infraumbilical region. And M5 denotes the suprapubic area, extending right down to the pubic symphysis.
And the lateral hernias.
Lateral hernias are categorized L1 through L4, denoting the subcostal, flank, iliac, and lumbar regions, respectively.
That establishes the geographic location. But then we evaluate the size. And here is a question frequently raised by junior registrars. When evaluating a hernia, why does the width of the defect dictate the complexity of the surgical reconstruction far more than the vertical length?
Grasping that concept is a fundamental leap in surgical reasoning. The vertical length of the hernia, for instance, a defect that extends 15 centimeters from the M2 epigastric region down to the M4 infraumbilical region that primarily dictates the length of your surgical incision and the longitudinal dimension of the mesh required.
It's just a matter of incision size.
Exactly, but the width. The transverse width dictates the biomechanical physics of the entire operation. Width is categorized by the EHS as W1, which is less than 4 centimeters, W2, 4 to 10 centimeters, and W3, greater than 10 centimeters.
Let's break down the physics of that W3 measurement. Why is a wide defect the hinge point that alters the entire operative strategy?
Because transverse width directly correlates with tension. The width determines whether you possess the physical compliance to mobilize the two edges of the rectus abdominis and bring the linea alba back together in the midline.
Okay.
If you are addressing a W1 defect, say 3 centimeters wide, the lateral muscles haven't retracted significantly. You can usually reapproximate the native fascia with primary sutures under perfectly acceptable tension.
But consider a W3 defect that is like 12 centimeters wide.
Right. Over the years, the external and internal obliques have chronically contracted and laterally retracted. If you attempt to simply pull those fascial edges together across a 12-centimeter gap with heavy sutures, the lateral tension will be astronomical. You will entirely violate the compliance of the tissue.
What happens then?
The sutures will either tear through the fascia the moment the patient coughs, or you will induce life-threatening abdominal compartment syndrome. A 12-centimeter wide defect requires a fundamentally different reconstructive philosophy than a 3-centimeter wide defect, regardless of their respective lengths. A wide defect mandates advanced myofascial release techniques.
So how do we assess this complex compliance clinically? You are in the exam room face-to-face with the patient.
The evaluation commences with a rigorous, targeted history. The paramount screening questions revolve around incarceration and strangulation. Has the hernia contents ever become irreducible? Does the patient experience localized, excruciating pain overlying the defect?
You're screening for emergencies.
Yes. Are they describing symptoms indicative of intermittent partial bowel obstruction, such as postprandial nausea, episodic vomiting, or severe bloating? Following the history, you perform a dynamic physical examination. You must examine the contour and defect with the patient standing and then supine, and you must palpate the fascial edges while they perform a Valsalva maneuver to increase intra-abdominal pressure.
And during palpation, you must maintain a really high index of suspicion for the Swiss cheese abdomen.
That is a critical trap to avoid. Frequently, a patient presents with what visually appears to be a single, massive, continuous bulge protruding from the midline. But upon meticulous palpation, you realize it is actually 3 or 4 distinct fascial defects, separated by narrow, intact bridges of aponeurosis.
And if you miss them?
If you fail to identify the smaller cranial or caudal defects and only reinforce the primary dominant hole, the patient will return with a recurrence through the missed defect almost immediately.
Which highlights the inherent limitations of the physical exam, particularly in a patient possessing a thick layer of subcutaneous adipose tissue. I mean, palpating a 1-centimeter Swiss cheese defect through 5 centimeters of fat is nearly impossible.
Which is precisely why cross-sectional imaging is a non-negotiable requirement. A multi-phase CT scan of the abdomen and pelvis is absolutely mandatory for any large, obese, recurrent, or anatomically complex incisional hernia.
It's the map.
The CT scan replaces subjective palpation with objective data. It provides the exact transverse width in millimeters. It delineates the contents of the hernia sac, differentiating between incarcerated omentum, loops of small bowel, or even segments of the transverse colon. It explicitly maps out every occult Swiss cheese defect. And most importantly, it allows the surgeon to perform volumetric analysis.
Let's dive into the implications of that volumetric analysis, because this introduces a profound physiological concept. What occurs when the hernia sac residing entirely outside the abdominal cavity becomes the primary residence for the patient's visceral organs?
You are describing the clinical phenomenon known as loss of domain.
The abdominal cavity has literally forfeited the right of domain over its own intra-abdominal contents.
Yes. Consider the natural history of a massive, neglected incisional hernia. Over years, driven by chronic pressure, more and more volume of the small and large bowel slides out of the primary cavity and takes up residence within this massive peritoneal sac hanging anterior to the muscle wall.
And what happens to the cavity they left behind?
While this is occurring, the true abdominal cavity undergoes a profound physiological adaptation. Nature abhors a vacuum. Because the cavity is empty, it shrinks. The diaphragm descends lower into the thorax, the lateral abdominal muscles contract and shorten. Eventually, the patient reaches a critical tipping point. The volumetric mass of the viscera residing inside the hernia sac is significantly greater than the available volumetric capacity of the shrunken abdominal cavity.
Let's translate that mismatch to the operating table. What happens if a surgeon fails to recognize this volumetric discrepancy, opens the patient, physically forces all of those externalized organs back inside the contracted cavity, and aggressively reefs the fascia closed over them?
They will initiate a rapid iatrogenic physiological cascade known as abdominal compartment syndrome. By forcing the viscera into a space that can no longer accommodate them, the intra-abdominal pressure spikes from a normal 5 millimeters of mercury to levels exceeding 20 or even 30 millimeters of mercury.
And that extreme pressure exerts devastating effects on multiple organ systems simultaneously. Let's walk through that systemic failure, starting with the pulmonary system.
The massive intra-abdominal pressure forcefully pushes the diaphragm upwards into the thoracic cavity. This dramatically reduces the functional residual capacity of the lungs, causing immediate basilar atelectasis, severe ventilation-perfusion mismatch, and acute hypoxic respiratory failure.
And the cardiovascular system.
Simultaneously, the pressure compresses the inferior vena cava, severely impeding venous return to the right heart. This drastic reduction in preload leads to an acute drop in cardiac output and profound hypotension.
What about the kidneys?
Furthermore, the direct mechanical pressure compresses the renal parenchyma and the renal veins, completely obliterating the glomerular filtration gradient and causing anuric acute kidney injury. And finally, the splanchnic circulation is compromised, leading to mesenteric ischemia and bacterial translocation from the gut mucosa. If unrecognized, abdominal compartment syndrome will kill the patient in the ICU.
The clinical takeaway is paramount. When you calculate a significant volumetric loss of domain on a preoperative CT scan, you must mentally shift gears. You are no longer merely planning a hernia repair. You are undertaking a staged abdominal wall reconstruction. You must formulate a strategy to actively expand the volume of the abdominal cavity before you can ever safely attempt fascial closure.
It ceases to be purely a surgical procedure. It becomes a complex physiological engineering problem.
Let us assume we have rigorously mapped the defect. We know the EHS width, we have calculated the volumes, and we have ruled out severe loss of domain. We're preparing for the reconstruction. Let's establish the geometry of repair. What are the non-negotiable pillars of a modern, durable hernia repair?
We operate on 4 foundational principles. Pillar 1. You must safely access the abdomen, reduce the herniated contents, and perform meticulous adhesiolysis to free the bowel from the abdominal wall without causing unrecognized enterotomies.
Okay, safety first. Pill 2.
Pillar 2. You must strive to restore the linea alba. The goal is to bring the native medial fascial edges back together. You are not simply applying a patch over a defect. You are restoring the functional dynamic continuity of the patient's core musculature.
Pillar 3.
Pillar 3. You must reinforce that primary fascial repair with a prosthetic mesh. And Pillar 4. You must ensure a wide overlap of that mesh beneath healthy tissue, deployed with minimal to zero tension.
Let's focus our attention on the third pillar, the mandatory use of mesh. Because occasionally, particularly with smaller incisional hernias, you might still encounter a surgeon who reasons, well, this defect is only a few centimeters. I have modern heavy-duty synthetic sutures. I'll just close it primarily and spare the patient the morbidity of a permanent foreign body.
And in modern surgical practice, that is an absolutely indefensible strategy for any meaningful incisional hernia. The clinical evidence was entirely settled over 2 decades ago.
The Lewis-Dyke trial.
Yes, the Lewis-Dyke trial. In the year 2000, they rigorously randomized patients presenting with incisional hernias to undergo either primary suture repair or mesh-reinforced repair. The results were staggering. The cumulative recurrence rates at 3 years with suture repair alone approached 46%.
Nearly half the patients failed.
Half. In contrast, the mesh cohort demonstrated a recurrence rate of 23%, a literal halving of the failure rate. This trial definitively ended the debate.
But I'd push back on that. Suture technology has advanced since the 1990s. We have superior, slowly absorbable monofilaments now. Does the Lewis-Dyke data really still hold weight today?
It absolutely holds weight because the fundamental problem was never the tensile strength of the suture material itself. The problem is the biological substrate of the fascia it is anchored into.
Ah, the collagen disease we talked about.
Exactly. As we discussed, the incisional hernia patient harbors altered collagen and hyperactive MMPs. A primary suture closure concentrates immense focal pressure on this biologically compromised tissue. Eventually, regardless of how strong the suture is, the suture will cheese wire right through the weak fascia.
So the mesh is the only way to spread the load.
Yes. The mechanical advantage of the mesh is that it broadly distributes the intra-abdominal forces over a massive surface area while simultaneously inducing a profound, widespread fibrotic response that incorporates the mesh into a new synthetic biologic composite layer. You need the mesh to overcome the biological deficit.
Accepting that mesh is mandatory, the next critical operative decision is placement. Where in the anatomical strata does this prosthetic actually belong? Because the surgical plane is everything. Walk us through a sagittal cross-section of the abdominal wall, from superficial to deep, and let's critically evaluate the biomechanics of each potential anatomical home for the mesh.
Let us begin in the most superficial plane, immediately deep to the dermis. You have the subcutaneous adipose tissue, and directly beneath that lies the anterior rectus sheath. If a surgeon reapproximates the fascial defect and then places the mesh directly on top of the anterior fascia, securing it like a blanket, that is termed an onlay repair.
What are the biomechanical pros and cons of the onlay approach?
From a purely technical standpoint, it is highly accessible. The surgeon doesn't have to dissect deeply into the muscular compartments. However, the physiological downsides are severe. To deploy sufficiently wide mesh in the onlay position, you must surgically elevate extensive flaps of skin and subcutaneous fat off the underlying anterior fascia.
And what does that do to the blood supply?
It destroys it. This extensive undermining severs the delicate perforating blood vessels supplying the skin, risking full-thickness skin flap necrosis. Furthermore, it creates an immense potential dead space between the fat and the mesh. The mechanical shear forces between the mobile subcutaneous tissue and the fixed mesh result in notoriously high rates of chronic seromas.
And if they get an infection?
If a superficial surgical site infection develops, the bacteria have direct, unimpeded access down to the prosthetic mesh, often resulting in a devastating deep space infection.
The morbidity profile of the onlay makes it pretty suboptimal. Let's move deeper. You incise the fascial defect and enter the abdomen. You encounter the bowel. Instead of attempting to mobilize the tissues to close the fascia, you simply cut a piece of mesh to the exact dimensions of the hole, and you suture the edges of the mesh directly to the edges of the fascial defect, much like sewing a patch onto a punctured bicycle tire.
That technique is known as an inlay, or an interposition bridging repair, and from a biomechanical perspective, it is a profound trap.
I want to explore why it's a trap. Because to a novice, it sounds entirely logical. If you have a gap, you bridge the gap with a strong prosthetic.
It is a trap because it completely ignores the physics of intra-abdominal pressure and Laplace's law. In a bridging inlay repair, the synthetic mesh is only as strong as the physical suture line holding it to the fascial edge. There is zero overlap of the mesh onto healthy tissue. It relies purely on point fixation.
Oh, I see.
When the patient's intra-abdominal pressure rises, or when the lateral oblique muscles forcefully contract, all of that immense outward and lateral force is concentrated entirely on those few millimeters of fascial edge where the sutures are anchored. Over time, those sutures will inevitably pull through the fascia, and the hernia will recur around the periphery of the mesh. Bridging inlay repairs demonstrate unacceptably high long-term recurrence rates and are generally abandoned by abdominal wall reconstruction specialists.
So if onlay is plagued by wound morbidity, and inlay is a biomechanical failure waiting to happen, where is the optimal plane? Where do we find the promised land for mesh integration?
We must dissect deep to the rectus abdominis muscle. This leads us to the sublay plane, specifically the retromuscular space, which is globally recognized as the Rivstapa repair.
Walk us through the anatomy of the Rivstapa.
In this technique, you incise the medial edge of the anterior rectus sheath, physically retract the rectus abdominis muscle anteriorly, and meticulously dissect the avascular areolar plane between the posterior aspect of the rectus muscle and the anterior aspect of the posterior rectus sheath.
Creating a pocket.
Yes. You develop this retromuscular pocket bilaterally, reapproximate the posterior sheaths in the midline to isolate the bowel, lay a broad sheet of macroporous synthetic mesh within this space, and finally close the anterior rectus sheaths over the mesh.
Why is the retromuscular sublay considered the modern gold standard of hernia repair?
Because it elegantly harnesses the laws of physics, specifically Pascal's principle of fluid mechanics.
Let's dive into the physics of Pascal's principle as applied to the abdominal cavity.
Pascal's principle states that a pressure change occurring anywhere in a confined incompressible fluid is transmitted throughout the fluid such that the same change occurs everywhere. Inside the sealed abdominal cavity, you have continuous positive hydrostatic pressure pushing outward in all directions.
So how does the mesh benefit from that?
In a retromuscular sublay repair, that intra-abdominal pressure pushes outward against the posterior rectus sheath. The posterior sheath, in turn, is forcefully pressed outward against the overlying mesh, which pins the mesh securely against the posterior belly of the rectus abdominis muscle. The patient's own physiological pressure acts as the primary fixation device, constantly holding the mesh tightly in place, rather than attempting to blow it out through the defect.
The mechanics are brilliant. It turns the enemy intra-abdominal pressure into an ally. And what about the biology of this sublay plane?
The biology is equally elegant. The mesh is entirely enveloped within a highly vascularized compartment, sandwiched between the rich capillary beds of the rectus muscle and the posterior sheath. This exceptional perfusion promotes rapid and robust angiogenesis and fibroblast ingrowth, leading to swift tissue incorporation.
And it's safe from infection.
Furthermore, because it resides deep to the rectus muscle, it is completely shielded from superficial skin infections. And because the posterior sheath remains intact beneath it, the bare synthetic mesh never comes into contact with the underlying bowel.
It is the optimal convergence of biomechanics and wound healing. But let's descend one layer further. What if we deploy the mesh entirely inside the true abdominal cavity?
That describes the intraperitoneal onlay mesh, or IPOM technique. The mesh is placed directly against the parietal peritoneum on the interior surface of the abdominal wall. This plane is frequently utilized in standard laparoscopic ventral hernia repairs because the surgeon enters the peritoneal cavity directly and can easily deploy the mesh against the ceiling of the abdomen.
But there is a glaring physiological conflict here. If the mesh is deployed inside the peritoneal cavity, it is in direct physical contact with the visceral organs. Doesn't bare synthetic polypropylene mesh incite a massive inflammatory response when exposed to bowel?
It absolutely does. If you place standard, uncoated, macroporous polypropylene mesh directly against the small bowel, the bowel will rapidly form dense, impenetrable, highly vascularized adhesions to the synthetic material. Over time, the constant peristaltic friction against the rigid mesh will cause the mesh to erode directly through the bowel wall, resulting in a devastating, life-threatening enteric fistula.
So how do you use IPOM safely?
Therefore, if you elect to utilize the intraperitoneal IPOM plane, you must fundamentally alter your prosthetic. You are mandated to use a specialized, highly expensive composite mesh. These composite meshes feature a dual-layer architecture.
What are the two layers?
The parietal side facing the abdominal wall is typically macroporous synthetic to encourage tissue ingrowth, but the visceral side facing the bowel is coated with a temporary anti-adhesive barrier, such as cross-linked hyaluronic acid, carboxymethylcellulose, or oxidized regenerated cellulose. This barrier physically separates the bowel from the synthetic polymer during the critical early phases of healing, theoretically dissolving over several weeks once neoperitonealization of the mesh has occurred.
To summarize the geometry of repair planes, bridging inlay is a biomechanical trap. The retromuscular sublay is the physiological gold standard. And regardless of the anatomical plane you select, you must adhere to the principle of wide overlap. You need at least 4 to 5 centimeters of mesh extending past the fascial defect onto healthy, robust tissue in every single direction.
Correct. The mesh requires an extensive footprint. You must mechanically cover not only the visible fascial defect, but also a wide perimeter of the biologically compromised tissue surrounding it, distributing the shear stress over the largest possible surface area.
Let us return to our clinical mapping scenario. You are operating on a patient with a severe W3 defect. The CT scan confirms it is 15 centimeters wide. You have meticulously dissected the retromuscular space bilaterally, preparing for a beautiful Rivestoppa sublay repair. You intend to reapproximate the anterior fascia in the midline. You place your heavy sutures, you pull medially with your instruments, and the fascial edges simply refuse to advance.
The tension's too high.
The tissue compliance is exhausted. The midline remains locked open by a 10-centimeter gap. The tension is palpable. How do we proceed?
This specific operative dilemma introduces the most sophisticated concept in abdominal wall reconstruction: component separation.
We must deeply understand the anatomical mechanism before we discuss the specific eponyms. When the defect is simply too wide to close, what are we anatomically manipulating? You mentioned earlier that the lateral abdominal wall is not a single solid block of muscle.
It is essential to visualize the lateral abdominal wall as a laminated structure, much like plywood. It consists of three distinct muscular layers, the external oblique, the internal oblique, and the transversus abdominis stacked upon one another. Each muscle is enveloped in its own aponeurotic fascial sheath, and each possesses a specific, distinct vector of contraction.
So they're all stuck together.
In their native state, these three layers are bound tightly together by intermuscular connective tissue, restricting independent medial movement. However, if a surgeon selectively and longitudinally divides the aponeurosis of just one of those layers, you disrupt the continuity of that specific layer's lateral pull.
You unlock it.
Yes. This surgical release liberates the remaining intact layers, allowing them to independently slide and advance significantly further toward the midline.
The conceptual analogy here is vital. You are not utilizing brute force to stretch the fascia until it begins to tear. You are surgically unlocking a specific anatomical layer, altering the geometric compliance of the abdominal wall to grant the remaining layers the freedom to travel medially.
That is precisely the mechanism. By strategically releasing a component, you can achieve up to 8 to 10 centimeters of unilateral medial advancement, enabling tension-free closure of previously impossible defects.
So how do we execute this release? Let's critically contrast the two dominant anatomical philosophies, the anterior approach versus the posterior approach.
The historical workhorse is the anterior component separation, pioneered and popularized by Dr. Oscar Ramirez in 1990. In the classic Ramirez technique, you begin at your midline laparotomy incision. You then dissect horizontally, raising massive skin flaps all the way out laterally until you expose the external oblique aponeurosis, lateral to the linea semilunaris.
You're going way out to the side.
Yes. You then make a longitudinal incision through the external oblique aponeurosis, extending from the costal margin down to the pubis. This physical division of the external oblique muscle releases the lateral tension, allowing the underlying internal oblique transversus abdominis and the entire rectus complex to advance medially.
The medial mobilization achieved by the Ramirez release is undeniably effective. But let's discuss the physiological cost. What is the collateral damage associated with that extensive superficial dissection?
The collateral damage is primarily vascular, and it's frequently severe. To access the lateral external oblique aponeurosis from a central midline incision, the surgeon must elevate immense lipocutaneous flaps separating the skin and subcutaneous fat from the underlying anterior fascia over a vast surface area.
What are we cutting when we do that?
During this extensive undermining, you systematically sever the critical periumbilical perforating vessels. These perforators branch off the deep inferior epigastric artery, travel perpendicularly up through the rectus muscle, pierce the anterior fascia, and supply the overlying skin. By dividing them, you essentially devascularize the central abdominal skin flaps.
Which means you may successfully reapproximate the fascia and repair the hernia, but the overlying skin subsequently undergoes ischemic necrosis. It just dies.
Yes. The classic anterior release is notoriously plagued by significant wound morbidity. The vast dead space created by raising the flaps inevitably fills with lymphatic fluid, creating massive chronic seromas. And the compromised blood supply frequently leads to marginal skin flap necrosis, wound dehiscence, and devastating superficial infections that can require weeks of vacuum-assisted closure therapy.
The severe morbidity profile of the anterior release compelled the surgical community to seek a more physiologically sound alternative, which brings us to the modern darling of complex reconstruction.
The posterior component separation, specifically the transversus abdominis release, or the TAR procedure, pioneered by Dr. Yuri Nowitzki.
Let's perform a deep dive into the specific anatomy of the TAR. How does it circumvent the vascular catastrophes of the anterior approach?
The brilliance of the TAR lies in its anatomical plane. In a TAR, you entirely avoid the subcutaneous tissue. You do not elevate any skin flaps, and you completely ignore the external oblique. You begin your dissection deep within the retromuscular rivestoppa plane we detailed earlier.
Behind the rectus muscle.
You are situated behind the rectus abdominis muscle. You dissect laterally until you reach the lateral border of the rectus sheath, the linea semilunaris. At this precise junction, instead of stopping, you incise the posterior lamella of the internal oblique aponeurosis. This incision exposes the underlying transversus abdominis muscle. You then longitudinally divide the muscular fibers of the transversus abdominis itself.
By transecting the transversus abdominis, the deepest muscular layer, what space are you entering?
You enter the vast preperitoneal and pretransversalis fascial space. Because you have divided the transversus muscle, you can now dissect in a bloodless plane all the way out laterally to the retroperitoneum, occasionally exposing the psoas muscle posteriorly.
That sounds massive.
It achieves two monumental reconstructive goals. First, transecting the transversus muscle utterly abolishes the lateral vector of tension, affording spectacular medial advancement of the rectus complex. Second, and perhaps more importantly, this deep lateral dissection creates an unimaginably expansive, highly vascularized pocket.
For the mesh.
Yes. You can deploy an enormous sublay mesh, sometimes measuring 30 by 30 centimeters, extending from the xiphoid to the pubis and laterally to the retroperitoneum, ensuring phenomenal overlap with zero tension. And the most elegant aspect. Because all of this complex dissection occurred deep to the muscular layers, the superficial periumbilical perforating vessels remain entirely undisturbed. The blood supply to the skin is perfectly preserved.
The TAR sounds like the ultimate reconstructive solution. It provides massive medial advancement, creates a pristine retromuscular home for a giant mesh, and avoids the ischemic complications of skin flaps. But I must introduce a pushback. The anatomy in that deep lateral compartment is highly complex. What is the critical danger zone during a TAR? What structures are we at severe risk of injuring when we are dividing the transversus abdominis?
You are approaching the primary vulnerability of the procedure, the segmental innervation, traveling precisely within the neurovascular plane. The delicate space sandwiched between the internal oblique and the transversus abdominis muscles are the intercostal nerves, T7 through T12.
The nerves that power the core.
Exactly. These segmental nerves travel medially to provide the essential motor innervation to the rectus abdominis muscle.
So if a surgeon is performing a TAR and they lose their anatomical orientation, dividing the transversus abdominis too far medially, or performing a careless blunt dissection,
they will systematically transect those motor nerves. If you sever the segmental innervation, the corresponding segments of the rectus abdominis muscle undergo profound Wallerian degeneration and denervation atrophy. The muscle loses all its dynamic tone, it thins out and becomes flaccid.
And what does that look like on the patient?
When the patient stands, the denervated portion of the abdominal wall will passively balloon outward, driven by intra-abdominal pressure. You will have iatrogenically created a massive asymmetric abdominal wall bulge, essentially a pseudo-hernia.
The clinical takeaway here is vital. A denervation bulge is a functional failure of the operation. Regardless of how perfectly your mesh is deployed or how securely the fascial defect is closed, the patient will still present with a protruding, dysfunctional abdomen. In complex reconstruction, anatomical precision is not an optional refinement. It is the entire basis of the operation. You must possess an intimate knowledge of where those neurovascular bundles reside.
The dissection demands meticulous precision. The transversus release must be executed medial to the neurovascular bundles, carefully preserving their trajectory into the rectus muscle.
We have extensively detailed the open reconstructive techniques. Let's pull back and discuss overall operative strategy. How does a surgeon integrate minimally invasive platforms? How do you select between an open approach, a laparoscopic approach, and a robotic approach?
Strategy dictates that you must meticulously match the surgical approach to the spectrum of the hernia pathology. The open approach, utilizing a standard Rivestapa or an advanced TAR, remains the absolute workhorse for the most formidable pathology.
Massive W3 defects.
Yes, massive W3 defects multiply recurrent hernias. Patients with dense visceral adhesions requiring extensive adhesiolysis, or those presenting with significant loss of domain. You simply require the tactile feedback and the bimanual dexterity of open surgery to safely restore the midline and manipulate a massive prosthetic mesh.
Where does standard laparoscopy fit into the modern algorithm?
Standard laparoscopy is highly effective for smaller to moderate primary or incisional defects. It typically utilizes the IPM plane we discussed, deploying a composite mesh intraperitoneally. The clinical benefits are well documented. Significantly smaller incisions, less postoperative pain, and a drastically reduced incidence of wound morbidity compared to open surgery.
But there's a downside to standard lap IPOMs.
Historically, many laparoscopic repairs were simply bridging IPOMs, failing to reapproximate the native fascia, which limited their long-term functional success.
Which introduces the rapidly expanding role of the robotic platform. It appears robotic abdominal wall reconstruction is dominating the surgical literature right now.
The robotic platform is truly a revolutionary tool in this specific field. It allows us to seamlessly merge the biomechanical durability of the open sublay techniques with the profound low morbidity benefits of minimally invasive surgery.
How so?
Utilizing the enhanced articulation and 3D visualization of the robot, a surgeon can meticulously dissect the retromuscular space, perform a highly precise robotic TAR while clearly visualizing and preserving the neurovascular bundles, primarily close the fascial defect with heavy barbed sutures, and deploy a large sublay mesh, all accomplished through 3 or 4 8mm incisions.
That's incredible.
The learning curve is undeniably steep, but for the appropriately selected patient, it offers an unparalleled synthesis of structural durability and rapid recovery.
Let us address the most daunting scenario in hernia surgery, the contaminated field. You are performing an incisional hernia repair, but the patient concurrently requires a bowel resection for a colovesical fistula, or they have a functioning loop ileostomy adjacent to the defect, or you are operating to explant an old, chronically infected synthetic mesh. You have active bacterial contamination within your surgical field. How does this alter your choice of prosthetic?
This specific scenario has represented a massive conundrum, sparking fierce debate within the surgical community for decades. The historical dogma, which you will still find printed in older editions of surgical textbooks, dictated that in a contaminated field, you must never implant a permanent synthetic mesh.
Right.
The rationale was that bacteria would rapidly colonize the inert synthetic polymer, create an impenetrable biofilm, and the patient would suffer a chronic, intractable mesh infection requiring eventual explantation. The mandated solution was to utilize biologic mesh.
Let's define biologic mesh for context. This refers to acellular tissue matrices derived from human cadaveric dermis, porcine dermis, or bovine pericardium. The theoretical advantage was that because it is a naturally occurring biological scaffold, the patient's own immune system, specifically macrophages and neutrophils, could readily penetrate the matrix, actively clear the bacterial burden, and eventually remodel the scaffold into native host fascia.
That was the prevailing theory that drove a multi-billion-dollar industry. But the long-term clinical reality has been deeply disappointing. The robust evidence supporting the durability of biologic mesh in contaminated fields is conspicuously lacking.
They just don't hold up.
The long-term recurrence rates are staggeringly high. The fundamental flaw is that in a contaminated environment, the biologic matrix is subjected to intense enzymatic degradation by both bacterial proteases and the patient's own upregulated MMPs.
So the body eats it.
The body frequently degrades and dissolves the biologic mesh long before a durable, cross-linked collagen scar can form. Essentially, the highly expensive mesh simply melts away, and the hernia reliably recurs. Furthermore, the financial toxicity is immense. We are routinely discussing tens of thousands of dollars for a single sheet of biologic matrix.
If biologics are proving biomechanically unreliable and financially ruinous, what is the modern evidence-based alternative for the contaminated field?
The paradigm has shifted heavily back toward utilizing synthetic mesh, specifically macroporous, lightweight, uncoated polypropylene or polyester mesh, even in clean, contaminated, or grossly contaminated operative fields.
I have to challenge that. It seems totally counterintuitive. Why doesn't the permanent synthetic polymer simply succumb to a chronic biofilm-driven infection?
The answer lies entirely in the microscopic architecture of the mesh, specifically the physics of pore size and cellular immunology. The critical requirement is that the synthetic mesh must be macroporous.
Macroporous, meaning large holes.
Yes. The individual pores between the polymer filaments must be large, typically greater than 75 microns in diameter. We must consider the relative dimensions of the combatants. A host macrophage, the primary white blood cell responsible for phagocytosing bacteria and orchestrating the immune response, is approximately 15 to 20 microns in diameter.
Okay, 15 to 20 microns for our immune cells and the bacteria.
A typical bacterium, like Staphylococcus aureus, is roughly 1 micron. If a surgeon implants a microporous mesh where the pore size is very small, say less than 10 microns, the tiny bacteria can easily penetrate the pores and hide. However, the larger macrophages cannot physically squeeze into those small pores to hunt them.
They can't fit.
Right. The bacteria are granted a physical sanctuary where they rapidly establish a robust biofilm, rendering the infection chronic and impossible to clear without explanting the mesh.
But if the architecture is macroporous,
If the architecture features large pores exceeding 75 microns, the macrophages, neutrophils, and newly forming capillary buds can freely and aggressively traffic throughout the entire mesh matrix. They can physically access every surface of the polymer filaments, aggressively hunting and clearing the bacterial load before a mature biofilm can organize. The large pores eliminate the bacterial sanctuary.
That is brilliant.
Therefore, armed with this immunological understanding, high-volume reconstructive surgeons will now confidently deploy a macroporous synthetic mesh in a contaminated field. We accept that the patient may develop a superficial or easily drainable surgical site infection, but we rely on the macroporous architecture and the host immune system to salvage and eventually incorporate the mesh, achieving a durable long-term repair.
The concept that microscopic pore size directly dictates the macroscopic immunological response is fascinating. Let us shift our focus away from the operative technique and examine the critical preoperative phase. Because you alluded earlier that for these complex, massive hernias, the intervention commences months before the patient ever arrives at the hospital.
I deliberately refer to it as a campaign. When you are addressing complex abdominal wall reconstruction, you are not merely scheduling a date for surgery. You are orchestrating an extensive, multidisciplinary campaign of preoperative optimization. The formal term is prehabilitation.
Let's outline the core tenets of this prehabilitation campaign.
First and foremost is aggressive preoperative weight loss. This is not merely a request for cosmetic optimization, it is a physiological necessity. Every single kilogram of adipose tissue a patient sheds exponentially decreases their resting intra-abdominal pressure.
Right, taking the load off the cylinder.
It mitigates the outward radial force we discussed earlier. Weight loss makes the physical dissection technically safer, it drastically lowers the tension required to reapproximate the linea alba, and it is independently associated with a significant reduction in long-term recurrence. Second, and equally uncompromising, is mandatory smoking cessation.
We mentioned the microvasculature earlier.
Yes. Attempting a complex reconstruction involving massive tissue flaps and extensive dissection on an active smoker is practically guaranteeing an ischemic wound catastrophe. Their nicotine-constricted microvasculature simply cannot support the metabolic demands of the healing tissue. Many reconstructive centers, recognizing this futility, mandate objective biochemical testing such as serum cottonine levels and will outright refuse to operate until cessation is verified.
Let's revisit the most extreme phenotype we discussed earlier, the patient presenting with severe loss of domain, where the volumetric capacity of the contracted abdominal cavity is wholly insufficient to safely accommodate the returning viscera. How do we prehabilitate that specific anatomical deficit? You cannot simply instruct the patient to stretch their abdominal wall.
For these severe anatomical discrepancies, we deploy two highly sophisticated adjuncts to actively manipulate the abdominal compliance prior to surgery. The first is chemical component separation utilizing botulinum toxin type A.
Wait, Botox. You were utilizing Botox injections to alter the abdominal wall musculature.
Exactly. Approximately 4 to 6 weeks prior to the scheduled reconstruction, under direct ultrasound guidance, we inject precise aliquots of Botox laterally into the muscular bellies of the external oblique, internal oblique, and transversus abdominis bilaterally.
How does that work chemically?
The botulinum toxin cleaves the SNAP25 proteins at the neuromuscular junction, effectively halting the release of acetylcholine. This induces a targeted, temporary flaccid paralysis of those specific lateral muscles.
What is the physiological consequence of paralyzing the lateral abdominal wall?
The muscles entirely lose their resting dynamic tone. They relax, and as they relax, the sarcomeres literally elongate. This chemical denervation provides incredible fascial laxity when you finally enter the operating theater.
Oh, wow.
A defect that appeared rigidly fixed and impossible to close in clinics suddenly becomes highly compliant. The Botox often allows us to reapproximate the midline with minimal tension, and in some instances, the drug provides so much medial advancement that we can entirely avoid the need to perform a surgical TAR, sparing the patient the morbidity of the deep dissection.
A medical component separation to augment or even replace the surgical one. That is remarkable. And what is the second adjunct for the most extreme cases of volumetric mismatch?
Progressive preoperative pneumoperitoneum, or PPP. This technique is reserved for the most severe, life-threatening instances of loss of domain. Several weeks prior to the definitive operation, an interventional radiologist percutaneously places a small catheter directly into the patient's peritoneal cavity. Then, on a daily basis, we slowly insufflate a calculated volume of ambient air through the catheter into the abdomen.
You literally inflate them over weeks.
Yeah.
You are intentionally and progressively inflating the abdominal cavity like a balloon.
Yes, precisely. We are inducing a controlled, gradual increase in intra-abdominal pressure. This continuous, unrelenting internal pressure acts as a slow tissue expander. It progressively stretches the contracted abdominal wall muscles, forcing them to lengthen.
And it trains their lungs too, right?
It pushes the diaphragm superiorly in a slow, controlled manner, forcing the respiratory system to incrementally acclimate to the higher intrathoracic pressures. By the time we transport the patient to the operating theater, the peritoneal cavity has been physically expanded and the physiology has been conditioned. The cavity can now safely accommodate the massive influx of returning viscera without triggering the catastrophic cardiopulmonary collapse associated with abdominal compartment syndrome.
The profound clinical takeaway here is that modern abdominal wall reconstruction is a meticulously planned, physiologically sound, staged campaign. It is the absolute antithesis of a single, heroic, fly-by-the-seat-of-your-pants operation.
The definitive operation in the theater is merely the final physical execution of months of rigorous metabolic and anatomical preparation.
So we have planned the campaign, we have optimized the physiology, and we have executed the precise surgical technique. But we must remain fiercely honest with the patient sitting across from us in the consultation room. What is the true cost of this campaign? When a registrar is obtaining informed consent for a massive abdominal wall reconstruction, what specific morbidities must they explicitly counsel the patient to expect?
Complete transparency is mandatory because all this is highly effective, life-altering surgery. It represents a massive physiological insult. It is never minor surgery. First, you must discuss recurrence.
The elephant in the room.
You must clearly articulate that even in the hands of an expert, utilizing the optimal macroporous mesh in the ideal retromuscular plane, these hernias possess the capacity to return, particularly if the patient harbors that underlying unmodifiable biological collagenopathy or if the initial defect was staggeringly large.
What other morbidities must be discussed?
Surgical site occurrences are nearly ubiquitous in complex cases. Seromas, the accumulation of lymphatic fluid in the dead spaces created by our dissection, are incredibly common, particularly if extensive component separations were required. They are largely an expected consequence of the inflammatory healing phase. While they usually resolve with time and conservative management, they are highly distressing to the patient and must be anticipated.
And the threat of infection.
Yes. A superficial surgical site infection in the subcutaneous fat can significantly delay healing and require prolonged wound care. But the registrar must counsel the patient on the catastrophic potential of a deep space mesh infection.
What happens if the mesh gets infected?
If the synthetic prosthetic becomes deeply, incurably infected, the ultimate salvage procedure is a massive reoperation to painstakingly explant the incorporated mesh. This procedure subjects the patient to immense morbidity and reliably leaves them with a fascial defect significantly larger and more complex than their original hernia.
We must also discuss the severe intraoperative risks, specifically regarding the bowel.
Unrecognized enterotomies. Patients requiring complex reconstruction frequently possess a hostile abdomen, multiple previous laparotomies, dense intra-abdominal adhesions, and bowel loops intimately adhered to the abdominal wall or to previously placed eroded mesh.
It's a minefield.
The extensive adhesiolysis required simply to safely clear the fascial edges is frequently the most arduous and dangerous segment of the procedure. A catastrophic, unrecognized thermal or sharp injury to the bowel during this dissection, especially when occurring adjacent to newly implanted synthetic mesh, can precipitate fecal peritonitis, overwhelming sepsis, and the total failure of the reconstruction.
And as we detailed during our discussion of the TAR, we must counsel them on the risk of denervation.
Absolutely. The risk of injuring the segmental neurovascular bundles, resulting in permanent muscular atrophy and a disfiguring functional abdominal wall bulge.
And finally, compartment syndrome.
Despite our best preoperative volumetric assessments, if the fascial closure is executed under excessive tension, the patient must be warned of the potential for postoperative abdominal compartment syndrome, which may necessitate prolonged mechanical ventilation in the ICU or, in extreme cases, emergent bedside reopening of the abdomen to save their life.
To summarize this risk profile, we are addressing a vast spectrum of disease. The complication profile and the potential morbidity scale exponentially with the anatomical complexity of the hernia. A W1 umbilical hernia repair in a healthy patient is an outpatient procedure. A multiply recurrent W3 incisional hernia presenting with significant loss of domain in a medically complex patient is a massive, life-threatening physiological undertaking.
You must respect the profound magnitude of the physiology you are manipulating.
Which brings us to the conclusion of our deep dive. We prefer to close out the discussion by stepping away from the raw anatomical data and focusing strictly on the cognitive framework, the what a thinking surgeon should ask checklist. When you, the listener, are evaluating that next challenging incisional hernia in the outpatient clinic, what are the 7 critical questions you must rigorously answer before you ever schedule that patient for the operating theater?
Number 1. Fundamentally, why did this fascial failure occur in the first place? Was it a mechanical failure due to poor suturing technique and infective complication, or is there an underlying systemic biological substrate? And critically, which of those driving factors can I actively modify today?
Number 2, is the defect comprehensively mapped? Have I documented the precise EHS classification? Do I know the exact transverse width in millimeters? Are there occult Swiss cheese defects that I cannot palpate? Is there impending loss of domain that mandates a preoperative CT scan to quantify the volume mismatch?
Number 3, can I safely restore the linea alba, and at what physiological cost? Will the native tissues stretch sufficiently? Will I be required to perform a component separation to achieve medial advancement? And if so, am I anatomically prepared to execute a posterior TAR safely, preserving the neurovascular bundles?
Number 4, what specific anatomical plane will the prosthetic mesh occupy? And regardless of whether I choose the sublayer or the IPOM plane, can I guarantee a sufficient 5 cm overlap onto healthy, robust tissue in all directions?
Number 5, is this operative field classified as clean, contaminated, or grossly contaminated? And based on the modern understanding of macrophage kinetics and bacterial biofilms, how does that bioburden alter my mesh selection? Am I defaulting to an expensive, easily degraded biologic mesh purely out of outdated historical habit?
Number 6, is this specific patient truly physiologically optimized for a massive reconstructive effort? Have we rigorously addressed their smoking status, their severe obesity, their glycemic control? Do they possess a volume mismatch so severe that they require Botox injections or progressive preoperative pneumoperitoneum simply to survive the fascial closure?
And number 7, the most deeply humbling question of all. If I proceed with this complex reconstruction today, and the hernia invariably recurs in 3 years, what will be the physiological mechanism of that recurrence? And did I execute every single strategy within my power today to prevent that specific mechanism from occurring?
Answering those 7 questions honestly and comprehensively implies a profound shift in perspective. It means you are no longer simply staring at a mechanical hole in a patient's fascia and devising a rudimentary plan to sew it shut. You are engaging in a much deeper, more complex endeavor.
You are meticulously reconstructing a dynamic, physiologically functioning abdominal core for a highly specific human being.
Take a moment to truly consider that. You are physically rebuilding the central load-bearing mechanics of their body, and accomplishing that requires vastly more than just adept surgical hands. It demands a rigorous, deep physiological understanding of every single biomechanical and cellular concept we have unpacked today. Which brings us directly to our core pedagogical creed.
Surgery must be fundamentally understood, not merely memorized.
So as you head back down to the outpatient clinic to see your next consult, or as you scrub your hands and step up to the table for your next long laparotomy, look incredibly closely at the physics of how you are closing that fascia. Remember the outward radial pressures. Remember the delicate biology of the collagen matrix. And remember the stark reality that the bulge you evaluate tomorrow is the definitive verdict on the suture you place today.
The structural integrity and the functional future of that patient's abdomen reside entirely in your hands.
Good luck out there.